Good afternoon and hello everyone. Welcome to today's event for our National COVID Learning Series leaning into the COVID-19 pandemic, sponsored by the National Association of Community Health Centers. My name is Elizabeth Breidenbach. I'm a meeting and event specialist based in the Clinical Affairs Division here at NAC, and I'm pleased to bring you this event along with my division colleagues, Luke Ertl from the Quality Center as a program manager, and Cheryl Modica, the Quality Center Director. Before we get started, I would like to review a few housekeeping announcements. You have joined this online event by either using computer audio or physically dialing in. All attendee lines have been muted and will be muted for the duration of this event. The duration of this live event is approximately 60 minutes, including introductions, presentations, and Q&A. Again, the duration of this event is approximately 60 minutes. You'll have two ways today to pose your questions, and we do encourage you to pose those questions throughout today's event. The Q&A box is located in the lower right-hand side of your computer screen. Please type your questions into this box at any time, select all panelists, and hit submit. Again, the Q&A box will be available for the duration of this event. Type in your questions, select all panelists, and hit submit. If we cannot get to your questions in the time allotted, an attempt will be made after the event is completed. We will also encourage verbally asking your questions today. There are going to be some that are going to be a little bit lengthier. We'd like you to pose verbally to us. If you do feel compelled that you want to ask your question live, verbally, essentially we'll unmute your line. Please use the raise my hand function. It's located actually directly next to your name. It looks like a very small icon with a little hand. Click that. That indicates to us that you would like us to unmute your line. We will verbally let you know right before we unmute your line that we're going to have you go live. Friendly reminders, today's event is being recorded. All attendee lines have been muted and will be muted for the duration of this event. The Q&A box is located in the lower right-hand side of your computer screen. We encourage you to place your questions for today's event in this box at any time for today's event. And then best is you'll be actually asked for a brief survey at the end of this event. This survey lets us know how we did, how valuable this event was to you, and directly informs us of future training and technical assistance. And now we'll go ahead and get started, and I'll turn things over to my colleague, Cheryl. Cheryl, it's all you.
Great, thank you. Good day, and welcome to the first in a three-part series that's building health center capacity to respond to COVID-19. This series is made possible through funding from the Centers for Disease Control and Prevention as part of NAC's COVID-19 related support and efforts. Over the course of today's call and in the two subsequent calls in this series, we'll focus on three topic areas, all of which focus on improved business operations and response to COVID-19, but very importantly, are topics and strategies which can be applied to other clinical conditions and business operations. As you can see from the screen, the three topics that we will cover in this series include business continuity planning, data and informatics, and promising practices. Each of the webinars in the series is designed to build on one another, adding content and depth over time, yet each will stand on its own in terms of offering unique content for those who may not be able or may not choose to participate in all three sessions. The dates of sessions 2 and 3, as you may have seen on the last screen, are November 18th and December 16th, respectively. As we approach the end of today's session, we'll have a link and some more information on registering for the second and third sessions if you haven't already. All webinars will take place at 1 p.m. Eastern Time on those dates. Now, to begin today's content, we'll begin with a focus on business continuity and the importance of business continuity planning to survival and sustainability during COVID-19 and other emergencies. This portion of our program is led by Jervine Williams, Director of Finance of Training and Technical Assistance with NAC. Jervine, turning it over to you.
Thank you so much, Cheryl, and thanks to everyone on the call. So when we were looking at the pandemic, we decided to do a project on business continuity planning. So NAC reached out to our national partners, Primary Care Development Corporation, otherwise known as PCDC, to help us with this. And the key staff at PCDC that we're working with is Deborah Johnson-Ingram and Isaac Kessenbaum, and they're here today to share some information as well. Next slide. So this is just, you guys know about NAC. This is a little bit more information about PCDC. They've been around for a long time and been a partner with us and working with health centers across the country. So we're just happy to have them on board because they have definitely experience in working with this business continuity planning topic. Next slide. So we're going to do some foreshadowing on what business continuity is. And I love this slide. It's like, what would you do? What would you do if you arrived to your health center and there's 2 feet of water on the floor? And this actually happened to me in my health center. Our health center was struck by lightning, and our admin was in the basement, and we got flooding, so we were shut down for a week. So this is why business continuity is so important, obviously because of the pandemic, but there's so many other ways that you can apply this. And with that, I'm going to turn it over to our PCDC partners to go a little bit deeper.
Thanks, Javine. Next slide. So what is business continuity? Well, it's an organization's ability to maintain essential functions during and after a disaster has occurred, as Jareen had just mentioned in her health center. It's part of a successful business plan. It's well-researched and to help identify hazardous circumstances so that a business can prepare to respond effectively and efficiently in light of a disaster. However, it's not a disaster plan, right? Having business continuity is an iterative process, right? It's something that constantly grows and changes, and it's supported by the senior management of an organization and funded by the organization as well. Next slide. Business continuity planning is the actual pre-work that we do that establishes all the risk management processes and procedures that aim to prevent interruptions to critical services, which in this case would be healthcare delivery. And it reestablishes full function to the organization as quickly and as smoothly as possible. Business continuity planning is important for organizations of any size. Small, medium, or large, every center should consider the development and implementation of the business continuity plan and conduct comprehensive training, testing, and maintenance programs. Next slide. What business continuity and planning is not? It is not your emergency plan at all. In fact, although when done right, your emergency management plan will talk to your business continuity plan, right? It's sort of, they exist side by side from one another. In some cases, the EM would be a subcomponent of the business continuity plan. Disaster recovery plans or emergency management plans involve restoring vital support systems immediately. The business continuity has a much wider scope and does not focus on specific events like a flood or fire or COVID, but instead on the processes a business utilizes every day. Finally, business continuity planning is not too difficult. It's not too time-consuming. It's not a waste of resources at all. And it's not unnecessary because as we've witnessed the impact of COVID on our health centers, those with good business continuity plans are less likely to fail. So next, I'm going to turn over to my colleague, Isaac, who will talk a little about the trainings we have in store for you guys.
Thanks, Deborah. If you can advance to the next slide. So just to give you a sense of what PCDC is going to help NAC and all of its constituents with over the next few months, we're going to put out a 4-part business continuity planning training covering 4 areas around, what is an intro to business continuity planning, a little deeper than what Deborah went over, how to create a business continuity plan, and we'll be creating a template to support each health center or provider in doing that. Number 3, how to make the business case to your senior leadership and to your funders that this is an important exercise, not only in the time of crisis, but in between. And number 4, ensuring a human resources strategy. Obviously, healthcare is a largely human and personnel-driven endeavor, so we want to make sure that we have the staff and personnel in place and safe to continue to deliver business. As I mentioned, we're going to create a template to support FQHCs through this. And we're also going to complete an action guide, which you should all be familiar with. I know NAC has put them out for other topics, but it's sort of a quick document to take you through the steps of business continuity planning so you don't have to rely on returning to the trainings. You can have sort of a quick document to review. Next slide. And just in closing for our part, this is just an example of what a template component may look like. This is where you keep your supplies in the case of an emergency, in case you need to stand up a new location or move things around within your existing facility. So it will be a series of templates that really help you answer the critical questions about how you continue to deliver your essential services in the community. And I'll hand it back over to Cheryl.
Great. Thank you. So thank you, Jervine, Deborah, Isaac. And for all of you on the line, you can hear that as part of this national COVID response, NAC is, as part of this three-part series, compiling together with some of our partners essential resource tools, action guides in the area of business continuity planning. So again, this was an initial opportunity to hear of more that's to come in our second and third series, and then more to come in a four-part training for those who also want to dive deeper and explore application of those templates, et cetera, that Jervine and her team just spoke about. So thank you all for that fabulous introduction and segue into or lead into an important area of health center response. And that leads us now into a focus on not only business continuity, but also data and informatics, and developing data strategies and enhancing collective data and informatics systems that can help centers in their response and recovery. And so for this next portion, our second segment in today's webinar, I'm going to turn the floor over to Dr. Julia Skapik, Medical Director of Informatics with NAC. Julia?
Hello, everyone, and thanks for joining us today. We're going to talk a little bit about how what we're doing in COVID-19 matches up with sort of our larger strategies to support health centers, PCAs, and HCCNs through data and health IT infrastructure. Next slide. I'm Julia Skapik, the Medical Director for Informatics. So these are some of the questions that we were hoping to address today, helping everyone to understand, although to some of you I'll be preaching to the choir, why a standardized data and coordinated data collection and reporting system is important. Telling you a little bit about what NAC is doing to advance efforts around this, and again, one of our biggest efforts around data is focused on COVID-19 right now, and then giving you some opportunities to, from the field, engage in the work that we're doing and get involved. Next slide. So many of you are familiar with the interoperability challenges that we see now in the current environment. And part of the reason for those challenges is because data definitions for different use cases or purposes are not harmonized. So you'll have a quality measure, and the quality measure will ask about the patient or one of their conditions in one way. The EHR definition might not match up to that perfectly. You want to do work on a research project, but they have their own way of defining it. So every time you go from use case to use case, you have to, these arrows represent data translations, and you have to manually sort of create and maintain a similar definition for the same kind of concept from use case to use case. It's very inefficient, causes a lot of challenges both for machines and for people as data goes from place to place. Next slide. And if we were able actually to capture data once and use that data seamlessly many times, we would have the opportunity to really take a big step forward in terms of some of our priorities. So it would help us to get better, accurate, more timely analytics. We could get better decision support tools, which of course would have to happen at the point of care, not after the fact. We can do better care coordination, right? If the mammogram can populate directly into the EHR, it should already turn off the alert reminding us to order it. And then the experience for the patient and for the care team is much better if we're not asking the same questions over and over again, entering the data over and over again, and doing a lot of effort to extract and send data to other stakeholders. Next slide. EHR architecture is unfortunately a part of the problem and not necessarily the solution because most EHRs have proprietary ways of describing information. It makes sharing data very difficult and requires all of that manual intervention to do those mappings. And it also makes it really hard for us to sort of plug and play tools created by others that many other industries benefit from, the sort of iPhone approach. Next slide. So these challenges actually came directly from our COVID-19 multi-state strategy project with CDC. There are a number of barriers to success in the field for what we want to do to help support health centers and also to be a productive part of the public health response. Lack of standardization and decentralization of data are always one of the biggest challenges. We need to know who was tested, who was diagnosed, who's getting admitted, what are the risk factors, how do we respond. Also, patient matching challenges can be part of the complications there. And then those data requirements for public health reporting, you don't have to tell us because we're hearing horror stories every day about how challenging it is when you have to report at multiple public health levels, and different public health departments have different requirements, and those aren't the same as CDC. Those aren't the same as the lab requirements. So the harmonization there really would add a lot of value. And then, of course, locally, these problems aren't special to COVID-19, but lack of use of standardized terminologies and lack of access to additional data sources. And the box on the right here shows some of the wish lists of some of our partners on the COVID-19 project. I'm sure many of you have wanted some of these things as well. Next slide. These are our partners in the multi-state strategy. The dark blue states represent where our PCA or HCCN partners are, and the light blue states are states in which they have FQHC partners. So it's actually a pretty broad-ranging project that touches about half the states in the country. Our goal is to build infrastructure to support data aggregation and data quality improvement, and then also to connect our partners to opportunities to innovate in HIE. And that includes things like electronic case reporting, as well as new analytics and new data sources. And at the same time, trying to work with CDC to describe the health burden, understand the health disparities, and look at the impact of COVID-19 on our patients and figure out what's working and how do we scale that. Next slide. In this project, we're looking at sort of the entire ecosystem. We know that you all don't do just screening or just follow-up. You do everything. You do surveillance, testing, case management, reporting, all of these activities. So as we look at those activities, we say the data has to flow from one thing to the next, and it should do that seamlessly, right? We shouldn't have to be re-inputting data or translating that data. And I'll mention for everyone that we're including looking at the flu response and flu vaccine as part of this effort. Now, it's maybe not directly called out on this slide. Next slide. One of the reasons we use the human-centered design framework is so we're really focused on sort of what are the needs of the users who are inputting data and gathering data, and how do we support them better, because we get better data quality when the users understand why we need certain data, when they don't have to do things like enter it in multiple places or enter it multiple times. And those, the people on the ground telling us sort of what their needs are and how to meet them better should be driving our solution. And this is a framework that NAC applies to all of our projects for public health and quality improvement in the informatics space. The tools shouldn't define the workflow should define the tool. Next slide. This is NAC's COVID-19 data architecture. This is sort of a very notional kind of picture of it, but basically what it represents is that we have all of these data sources out in the field. We provide a data dictionary where we try to create harmonization across these definitions, reuse the definitions you're already mapping and extracting. We can use APIs and data staging and pour that into our data lake, if you will. The data lake is where we stage the data and normalize it. We take the high quality data and push it into a relational database, and then we can plug in additional external sources of data, and we can create outputs for our partners like data analytics or reports. Next slide. So I'm pleased to introduce Raymond Uwe, and he's our physician informaticist, and he's going to walk you through some of our data activities. Go ahead, Raymond.
Hi, thanks, Julia. Hi, everyone. On the next slide, we just wanted to share with you what our NAC Informatics data strategy is. Julia mentioned the data dictionary, and in terms of COVID, we don't necessarily want to build something from the ground up. We want to use something that a lot of experts in the field have been using. So we've partnered with a couple of vendors, academia, in what's called the COVID-19 Interoperability Alliance, who have been creating value sets or lists of codes that can be used to help create data dictionaries or help pull data from different systems. So on the first line there, a data dictionary really provides a structure for creating a COVID-19 database that's really not encompassing hospitals, but ambulatory settings, or just like you guys, community health centers. We use terminology tools to build maps, which means, different health centers have used different electronic health record systems, which means different terminologies and, again, different proprietary codes. We want to map it into one single source of truth, which means we want data to mean the same things despite being in different health centers. And we work with our current partners to try to standardize that using a data dictionary and then do repeated extracts and automate the submission to a registry so that community health centers and NACHC and PCAs don't necessarily have to do all of these things. We can do it at an aggregate level. And then with those information, we can improve, again, data quality. And on the right side, you can see the different health centers submitting to a database. So we can do population level information, such as your numerators and denominators, and we can dive in deeper to the community level, facility, household, and even the individual level. On the next slide, I want to just quickly show you some data elements we're looking, some metrics in the data dictionary. On the right, you would see an Excel screenshot, but now we currently have a live living data dictionary that we're sharing with our partners where we collaborate. Different data types and elements that's COVID related. Visit types, is it a telehealth visit in person? Is it an in-person telehealth visit? There are those things. Demographics, which are also already included in the UDS, and there are some other types of demographics that might have popped up now that we're in COVID times. Labs related to COVID, obviously, risk stratification and social determinants of health. Which are not necessarily being pulled by the dashboards, your COVID dashboards that you're seeing right now. And also operations. We see that administrative and operations information are also important. We could also intake additional data sources from the Johns Hopkins University, NYT real-time reporting, and all those other good big dashboards that you've seen. And we also wanted to look at the impact of social determinants of health and COVID to see if whether or not different data elements, SDOH data elements, are impacting COVID management and COVID response, and how often do patients at risk become infected. So we want to look at different past medical history, different comorbidities, stuff like that. For the sake of time, on the next slide, we want to show a quick dive, but basically we dive into each partner and see what they have in the field. And using all of these things, we want to transition from what currently is happening, an interoperability nightmare, to a seamless and semantic interoperable system where people agree to a standard and things mean the same thing. Lastly, we want to show you on the next slide how we're engaging our partners. We have created a Confluence, which is like a Wikipedia page where all these things are held. And we also hold community health work groups targeted towards you guys on innovations, HIT innovations, and other partnerships that you guys can use to address COVID-19. And that's it. And we want to welcome you to engage with us, the Informatics team, with Dr. Skapik, myself, and my other teammates. And we want to ask you what are the questions that you want your data to answer in COVID. So thank you very much. Julia?
Yeah, and if I can just close it out by saying, please feel free. You can also email us now at informatics@nac.com. Reach out. We have a listserv that you can join, and there's a sort of general informatics Confluence site at NAC where you can get announcements about activities that our team is engaged in. If you go back one slide just for a quick second. So the COVID-19 Community Health Workgroup, we invite all of you to participate in that. Our first meeting should be, we haven't quite nailed down the day and time. It should be about 2 weeks from now. And we'll be talking and presenting about not only some updates on the COVID-19 project, but talking to some of our partners at CDC who are doing electronic case reporting and engaging folks in discussing sort of what the needs of the community are. We have a number of partners at other federal agencies who are interested in how they can help to contribute to community health centers. And so we want your feedback so that they can hear your message and kind of provide their resources and input back to us. Thank you.
Great. Thank you, Julia and Ray. Wonderful segue into our final section. And so we started with focusing on larger business operations and continuity, critical in the time of a pandemic, and then transitioned in looking at data and informatics, and Julie and Ray and the informatics team. And now we're going to drill down just to another level further and look at promising practice models. And we're going to have two health center individuals who mobilized early and effective responses in the time of COVID-19, and to hear from them about some of their work and lessons learned that are applicable not only to the current COVID-19 pandemic response, but also are applicable in terms of many future clinical conditions or other emergencies. And so we're going to begin this two-part health center lens with Sherilyn Johnson, who's Director of Quality Improvement at South Boston Community Health Center, where she supervises the quality and informatics team, works on population health workflows, and oversees the QI program there. She's been caring for COVID-19 patients and works closely with senior leadership to do what many of you on the line have been doing in terms of trying to translate state and federal regulations into actionable and operational workflows and protocols on the front line. Previous to her current position, she also served as Director of Medical Informatics and a primary care provider at Upham Corner Health Center in Dorchester. And so we're very excited to have you here today. Sherilyn, I'll turn it over to you.
Thank you so much, Cheryl, and thank you to NAC for having me today. What a rich learning collaborative this is, and I'm just delighted to be part of this with you all today. Really think this is really important work that all of you are doing. I had a chance to read through the best practices toolkit, and I'm just blown away by the innovation, the rich collective knowledge that we bring. This is such an important moment, and health centers are on the front lines of addressing these disparities in health equity. So I just applaud everybody that's been part of this. And to continue in that spirit of celebration, what I'm talking about today is really a celebration of the teamwork at our health center, our clinical operations leadership, our nursing workforce, our quality improvement and clinical informatics team. Have all been part of this all along the way. It's been one giant QI initiative, and I'm very excited to share today. So my aim is really to share the story of how using an EHR-based flow sheet tracker to look at COVID symptoms over time has improved the safety and quality of care for our patients. It has allowed for greater consistency in the clinical guidance that we're giving and the documentation that we're doing, and it has given us structured data. So I really appreciate the comments about how important it is to have harmony in data. So has provided that for us in terms of our COVID care. And this is probably my favorite outcome of this intervention, is actually the fact that it empowers our nurses to feel a little bit more settled going home at the end of the day, knowing that they've called everybody with the highest acuity conditions, and that's been a real peace of mind thing for them. Next slide, please. So I'm preaching to the choir here when I talk about why COVID patients need follow-up. This is a complicated disease. After 7 months of seeing patients in our COVID clinic, I like to say that if you've seen one case of COVID, you've seen one case of COVID. There's such wide variability in how people are experiencing this disease and what symptoms they're having, what the linear progression of symptoms over time is. Makes it very difficult to predict outcomes just based on anecdotes. So a lot of us in the beginning, our providers would come together and say, I don't have a spidey sense about what is going to happen to this patient. And typically, alarm signs are alarming to patients, and this was a disease that was sneaking up on people and actually taking lives precipitously at home. So we, very early on, our clinical leadership said we have to start following up with all these people until we have more data to guide our decision making. And so regular follow-up calls became our mainstay, and our nurses have been the backbone the whole way through. So what it looks like for us is our nurses calling patients who qualify for active tracking every 1 to 3 days, and we have a flow diagram. I'll show you in a little bit how we categorize that. But to qualify for active tracking, our patients who have either suspected or confirmed COVID end up getting put into a report, and they must be stable enough to recover at home. They end up going to the hospital and then getting discharged. We'll add them back into active tracking. And then right now, this is our current algorithm. In the beginning, we were putting everybody who had any symptoms at all, even if they were mild, into active tracking. We know a little bit more information now. We're more comfortable just putting people with moderate symptoms or mild symptoms with a positive test result into active tracking. And this has really come to help our nurses just in terms of managing the volume. Once we reached the 100 patient mark, our mechanism that we started out using, just having all of those notes queuing up in an in-basket, was getting too much for the nurses to manage effectively, and they started to feel really anxious about patients falling through the cracks. And then we also realized on the flip side, not all these patients were really sick and needed daily phone calls, and some of them were pretty annoyed. They're like, why are you calling me again? So we realized, okay, we need something that's going to help us to organize this. So next slide, please. So here it is, at least a mock-up due to licensing agreements. I'm not able to show you the actual tool, but this is pretty much what it looks like when it pulls into the notes. You can see that it kind of serves multiple purposes here. You're able to see the linear progression of the disease over time. And some of the things that are highlighted red were things that from our partnering hospital, Boston Medical Center, we early on identified as key points to just pay attention to and just have a lower threshold for kind of stepping up the level of care. So it's pretty neat, too, that we're able to filter. We worked very closely with our EHR partner and with our CIO and myself together, both being Epic certified provider builders. We were able to build this very quickly. We got it live by April 13, and our nurses started using it systematically. And what's cool is it just allows the nurses it prompts the questions that they ask every time that they follow up with the patients, but it also serves as their documentation. So they're asking the questions, they're putting the answers in, and then it's one and done. Their notes pretty much complete at that point. So, and then we're able to filter. You can see the little icon, that looks like a funnel next to some of the rows there. And those 4 rows have been crucial to organizing the follow-up calls. So day of symptoms, the overall status, which is the patient-reported status, the symptom summary, which is the clinician's assessment, and then the disposition, which is where we would put things like referred to the emergency room, admitted, intubated, and it just gave us some structured data elements to then dig into what were, rates of admission and other things that have been really important to managing our strategy for our COVID response. Next slide. So at a high level, this is kind of an overview of how patients would qualify for active tracking. These are some of the key elements that would put somebody into our master COVID report. Either they had a diagnosis of COVID, a lab test was ordered, or they had a visit in our COVID clinic. Then our care management nurses would take turns each day reviewing the new patients added to the master report. And if active tracking was indicated, they would add a COVID episode, which would then put them into this third bubble, the report that our team nurses are filtering based on the PCPs whose patients they're following up on, and then able to prioritize by the symptom summary, the patient's reported status, any of those 4 variables, as well as a number of other data elements that we already have in our record, like the last COVID lab results, for example. They're tracking that outreach, and there's a way for us to actually put into the report the next time the patient's due for outreach, and this turned out to be a real boon to the effort. Our nurses, over time, as they built the report up, were able to then filter by who's due for a call today, and they just run down that list. And it was one of my favorite things during the peak of COVID in Boston in April, was just to run yesterday's report and see the people who are due for calls and have 0 people show up on that report. It's so satisfying just to know that everybody had been outreached who needed to be called. So next slide. So here's the flow diagram and just a couple stats there. You can see we've reached nearly 1,900 patients using this flow sheet for a total of over 36,000 individual row entries that was as of last week. And then with about a third of those entries happening during the peak in Boston. Next slide. And then I've been working, too, with our vendor, Ocean Epic, and our research team there, and they've been really wonderful to work with on all of this, too. And we started to kind of share the tool more widely. I presented on our EHR's call in May and again in July, and just kind of shared how we were using this. And so the whole toolkit is available to any folks, any health centers that are using Ocean. Are welcome to jump right in, just open a JIRA, and if you have questions, you can reach out to me as well. And for folks not using Ocean, but who are interested in leveraging some of the definitions and the data that we've used, I'm happy to collaborate as well. But as you can see, we've had a fair number of health centers across the country try it, with most recently Georgia and Wisconsin have added the cohort of folks who are actively using it, actually. And so we have about 5 health centers other than South Boston currently who are using this for a little bit more consistently. So Next slide. And then one of the really important pieces of all this is hearing from the people who are doing the workflow. I love how Julia said, don't make the tool define the workflow, let the workflow define the tool. And that's absolutely what we've done the whole way through. We've really had an ear to the ground for our nurses and how is this working for them. And as you can see, very positive feedback from our nursing team, all of them. And I made sure, by the way, that they didn't feel like they had to say this is great because I was so cheerful and pumped about it. I said, you have to tell me if there's a problem with this because we don't want to recommend something that doesn't really work very well. So I hope they felt like they could be really honest with me. And by and large, they said this is working really well. So yeah, that's a piece of our story. Thanks for listening.
Great. Thank you, Sherilyn. I'm sure there'll be more questions when we get to that very shortly. But our last speaker for today and our second health center presenter is Sarah Benedetto, who's Chief Operating Officer with the Center for Family Health. Sarah is a registered nurse who's held a variety of positions in her 10 years with the center, including oversight of pharmacy, the community health, school health centers, health information, behavioral health, and clinical support staff. And her expertise and passion center around the design and execution of creative strategies and approaches for optimizing the health and well-being of our patients and her community. And so I think you'll hear a little bit about that passion and expertise and what she'll share with us on their home vital sign monitoring program. So Sarah, turning it over to you.
Thank you, Cheryl. Good afternoon, everybody. Thank you for having me here today. I'm really happy to be here and be part of the team of folks that you have presenting today. I've learned lots of things, and I've really enjoyed participating in the workshop today. So hopefully I'll be able to share a little bit with you about some things that, that we have found that have been very helpful to our patients and that you may glean something from our experience as well. Just to start off, the first slide, you saw some of our background about who we are, the patients that we serve. And why did we take this initiative on in terms of monitoring some home vital signs? And I want to start by saying that it's really a low-tech response. We are not doing a full-on home monitoring program where we're connected to our computer, to our system, Epic, but more by trying to get equipment into the patient homes for them to monitor, to self-monitor at home, and then also to make sure that they can report that information during telehealth visits or bring that information to them for their follow-up in-person visits, and also with our care management team who does follow-up visits over the phone. So that's really why we started this project. So you can go to the next slide. One of the things that we looked at initially way back in April is that we knew, like everyone else around the country, that many of our patients were most at risk with our patients with our uncontrolled diabetics, uncontrolled hypertension, patients with other chronic conditions as well. And we also knew that group was the group that we really wanted to make sure continued to have access, but also that we could continue to monitor some of their vital signs at home, knowing that they were not comfortable coming into the office, or maybe our physicians felt that it was best for them to do a televisit. We currently do about 95% of our visits are in person right now, but we are finding that it's still helpful to continue to work with these groups of patients and getting the equipment into their home. You can go to the next slide. So what we did is we purchased scales, blood pressure cuffs, and pulse oximeters to use to give to our patients. We also recently, in the middle of all this, received 50 glucometers from a local service club who felt that wanted to be able to participate in our community and make sure that our patients had access. We initially thought that we wouldn't have a lot of takers with that because most of our patients that are diabetic have access. We work with them through our care management team to make sure they have access to getting those supplies. But what we found is that those went very quickly, and within the first couple of weeks, they were all given out. So we are going to be purchasing some additional ones to use because we're finding that many of our patients are still having trouble purchasing the strips and to go along with the glucometer. So that is something that we'll be looking into. We originally ordered or received 500 blood pressure cuffs and 100 scales. One of the things that we did with our scales is we realized that in an effort to reduce exposure for our patients coming into the office, that it was going to make more sense for us to weigh patients in the exam rooms. So with the initial purchase of our scales, many of them actually went into our 70-plus exam rooms across our health system so that patients would not have to stand in the hallway and they could go right into the exam room. And now we are getting ready to purchase another batch so that we can get them into some patient homes as well. So you can go to the next slide. And so how are we getting this equipment connected to our patients? Initially, what we started with was identifying patients using reports out of our EPIC system to identify folks that had uncontrolled diabetes, uncontrolled hypertension. And then we connected our community health worker team with our patient care managers, our RNs, and the two of them would do, or the teams would decide which patients to reach out to. And then the community health workers would actually reach out to the patient and take them to the patient's home. So, and along with that was education with how to use the equipment. We were fortunate to, a couple months prior to the COVID pandemic, we had completed some training for our community health workers on the basics of hypertension and diabetes and the impact of that on patients. So it really worked out very well because they had some of that basic background. We just did a little bit of a refresher and then showed them how to use the equipment and how to actually teach the patient how to use the blood pressure monitors in particular. And then if some of the patients now are coming into the office, of course, most of our patients are, so we also are giving the equipment to them at the time of the visit. And finding that patients are really appreciating that and really getting engaged in the whole process and their health outcomes. You can go to the next slide. And getting to our outcomes. So we had a little bit of struggle with getting this off the ground initially. A lot of it, I believe, had to do with just so many of the basic challenges that we were all experiencing with keeping up with all of the other workflow processes and things that were changing due to COVID. So we really have noticed in the last month or so that we are really finding the staff are much more engaged in it, and our patients are very excited and really appreciate the opportunity to have the equipment in their home, and they're sometimes referring their family or friends that are also patients here to us so that we can get them to them. Our next steps is really to look at basically what impact has this had, how has this impacted patients from a qualitative and quality outcomes. So we'll be doing a deeper dive into some of the data to see if we're seeing increases or decreases in hypertension and hemoglobin A1Cs to see if what impact that it might be having. And we also just received our pulse oximeters. That took a little while for us to receive those in. So those we'll start to distribute in the next week or so as well. And along with all of this, I did want to mention too that our team that is participating includes our medical assistants, our providers, our community health workers, our patient care managers. We have a dietitian as well. And all of that includes, during all of this time, we were looking at what are the other social determinants of health needs that our patients might have. And what we found is that some patients, even with all of the opportunities for food, access to food, we are still finding that folks were having some difficulties getting that. So we've incorporated, we have opened a small food bank within our health center, and as they're taking the equipment out, that's one of the things that we're assessing, and we are taking emergency supply of food for folks and connecting them up to other more long-term sustainable solutions for the future. So with that, I think my time is about up, so I will close. Thank you very much.
Great. Thank you, Sarah. Wonderful. And while I'll queue up my colleague Luke Ertl in a moment and turn things over to him to manage some of the Q&A, I want to just share some information with those of you on the line that was referenced. I think our two last health center speakers alluded to some of the promising practices of a rich document that exists. And what they're referencing is this summer, NAC put out a call to the field to health centers across the country to share some of the best and promising practices that they had implemented or were still implementing in this era of COVID. And so we have compiled the 75 responses that we received from across the country, and those are a host of different experience, tools, strategies from ranging from primary care to dental care, workflows, HIT, et cetera. And so Camilla Silva just put a link to that document in the chat box. So we encourage you to go visit that document, and there you'll find a little paragraph that describes those 75 experiences from across the country, along with direct links to any tools that the health center submitted. So we hope that you find that as a useful resource and tool as well. And so with that, I invite all of you on the line to go ahead and let us know. I think there's some questions that have come in the chat box, but Luke, if you could come on the line, please, and share how you'd like to, if you'd like folks to raise their hands or enter in the chat box, and also any questions we have. Thank you.
Thank you, Cheryl. So yeah, we've gotten one question so far in the Q&A box, so please feel free to type in any questions, or as Cheryl and Liz had said at the beginning of the webinar, if you want to ask a question over the phone, please feel free to raise your hand and we will go ahead and unmute your lines. The first question that we have was for our last speaker. What type of blood pressure monitor did you use?
Okay, thanks. We used just a basic one. I don't have the brand name, but I'd be happy to share that. It's a very simple, basic self-monitor blood pressure cuff. It does not connect to our to the Epic system, so it's a very low-tech option. Just a standard standalone blood pressure monitor for self-monitoring, and it does operate with batteries or a charger.
Hey, Luke, I'm not sure if you're speaking, but your line is muted.
Thank you very much. Yeah, so our next question that we have is, how do you protect against data breaches in regards to HIE and interoperability?
I think that one's for me, right, Luke?
Okay, there was no specifics on that, but if you want to go ahead and jump in, please do.
Sure. Yeah, so one of the activities that our team is engaged in is figuring out how can we extend the work that we're doing by extending the data that we have available to ourselves. So as many of you know, things like quality measures perform based on whether or not anyone generally took the correct action, right? Not whether or not the health center took the action. So it actually, if we're not getting all the data coming into our system, it creates sort of a conundrum, right? The patient goes to the pharmacy down the street from them and gets the flu shot, right? If we don't have documentation of that, it makes it appear on our end as though we haven't given the patient the flu shot, but of course it would be inappropriate for us to give another flu shot to the patient to pass the quality measure. So one of the things that our team is very interested in is, both for flu and for COVID and sort of in general, is how do we make that data flow more effectively so that it comes into your system and it can do things like turn off alerts that are inappropriate, but also so we can follow up and close care gaps. So if the patient has an abnormal mammogram that was ordered by another provider, but now they're seeing us, it may be the opportunity, to make an early diagnosis. One of the activities that we're doing is both working at the health center level and working with the PCAs and HCCNs. If you're connected to an HCCN, it probably is a lot less effort for your FTHC to interface with the HIE by having the HCCN interface with the HIE. And we're working on creating sort of those data pathways so that those connections happen easily, and then you still only have that one connection to the HCCN. Data harmonization is part of that, right? The more standardized the data is, the easier it is to make those connections and to have the data flow seamlessly across from organization to organization. And, we're working on some curriculum to also help teach people about best practices, for example, automating testing procedures to make sure those connections not only are set up at one point, but that they are always working. And if they stop working, that we know when they stop working and we can figure out why, et cetera. Specifically for the COVID project, we've encouraged each one of the partners to identify at least one place where they'd like to make an electronic connection to a data source. And we'll try to help get that data moving. Ray, if you've got something else, please jump.
Of course, and just to add to that, the data that are being submitted are already de-identified, and we have measures for making sure that the data that are being submitted don't have PIIs or anything like that with regards to HIPAA. Yeah. Thanks.
Thank you all. We have another question that just came through that says, how is your health center prepared for and or address the staffing continuity challenge created when employees get infected or have to quarantine? And is there an increase in cross-training of similar positions possibly? And anyone can jump in on that.
I'm happy to speak to that. At our health center, we are, that has been a continual challenge. We have cross-trained several folks to do screening for entry into the building. We've just cross-trained a couple of dental assistants to start helping with our COVID testing in our drive-up curbside COVID testing clinic. Particularly, they are doing that on the weekends and evenings because we're open 5 nights a week till 9 p.m. and 8 hours each day on Saturday and Sunday. So that's overtime for them. It's worked out really well because it's not impacting their ability to provide to continue their dental assistant functions during the daytime. We've had other examples of that as well, where folks from other departments, our health department has staff that works evenings as a receptionist. So we've done a lot of cross-training. It's been very successful, and it's also generated a lot of collegiality and creativity between departments that didn't necessarily have frequent interactions prior to this time.
Thank you very much. Doesn't look like oh, go ahead, Cheryl.
Oh, and I was just going to say, if there is a question, we probably have time for one more because we just want to wrap up with a couple other housekeeping and some statements about the future webinars. Any more questions before us?
No more that I'm seeing at the moment.
Okay. Well, again, the good news for everyone is if you do have any questions that come up after we've hung up from today's session, there are 2 follow-on webinars in this series. And so for the session 2 on November 18th and session 3 on December 16th, we will continue this theme. So you will receive additional tools, applications, and information around business continuity. Similarly, you'll receive more follow-on around the data and informatics component. And then we'll also feature another 2 health centers that were part of our promising practices, that larger compilation, and we'll call out and share those experiences. So I think with that, you can see in the bottom right-hand side of your screen, if for any reason you haven't already registered for the full series or one of the 2 sessions that remain, you can use that link or you can scan the screen. And again, I think there's been a couple messages in our chat box that have reminded folks that of the location of where these slides will be available. So again, those are typically available several days following this webinar. And so with that, I think that brings us to the close. This is my contact information. I think you received the various leads contact information as we moved through the course of the presentation. If for any reason you didn't have a chance to jot that down and want to get in touch with anyone as a part of this call, feel free to reach out here, and I will be sure to direct it to the appropriate speaker. With that, we want to thank you for joining in the first of this 3-part series, and we hope you'll come back again in November and December for our second and third sessions. We thank our speakers for joining us today, and we wish you all a great day. Thank you.